All right, in this one, I have made four high-yield USMLE Step 1 style vignettes. I made them so we can cover multiple topics in one. This is for a lot of students who are, maybe nearing the end of their M1 year, starting to get ready for Step 2. We won't spend too long on these, but it's to kind of show you how one vignette can cover multiple different concepts. I'm also going to integrate some information. I've got a couple different like units in here that we'll go over. And so we'll kind of go from there. These are also going to be open-ended to allow you to kind of come up with the answer on your own to see kind of where you're standing. So, first patient, 40-year-old woman comes to the physician because of a 2-week history of fatigue, lethargy, and nausea. She has polymyositis treated with prednisolone. The patient recently started working shifts as a bartender and says she frequently forgets to take her medications because of the stress at work. Her temp is 98.8, her pulse is 85, blood pressure is 98 over 67. The abdomen is soft and non-tender. Bowel sounds are present. Neurological exam shows moderate weakness in the arm abductors and hip flexors bilaterally. The remainder of the exam shows no abnormalities. Morning serum cortisol and ACTH concentrations are decreased. 1 hour after administration of cosentropin, her serum cortisol concentration increases. So my question to you guys, compared to normal physiology, prior to giving the patient the cosentropin, what do you think her level of sodium, potassium, bicarbonate, and glucose would be? Would they be elevated, normal, or decrease? All right. So pause your screen, consider this vignette, and then we'll discuss. All right. So this patient, right off the bat, we should be thinking about adrenal insufficiency, right? There's a couple things that kind of key it in, but all in all, right, she's got the fatigue, lethargy, nausea. Those are very non-specific signs and symptoms, but they're very common in adrenal insufficiency. The patients often also have abdominal pain, right? But then we also see, right, we would kind of get down to the nuts and bolts. And her morning serum cortisol and ACTH concentrations are decreased. So that helps us kind of confirm the diagnosis of adrenal insufficiency. So it's up to us to decide, okay, is this primary or secondary adrenal insufficiency? And to throw a wrench into it, there's actually something called tertiary adrenal insufficiency that we consider a hypothalamic problem. But really, for my step 1 through like step 3 students, you really want to just consider primary is a problem in the gland itself, secondary is anywhere else. If you decide to become an endocrinologist, then you're going to really want to know all the nuts and bolts. But I think it's easier to just break it up: gland itself or a problem elsewhere, right? Um, so to understand, is this primary, secondary, that will help us then decide how to answer this question, right? So we have to first understand physiology of the adrenal gland, okay? So the adrenal gland, right, they sit right on top of my kidneys, and they're made up of the cortex and the medulla, right? The cortex is the outer portion. It's got 3 layers. The outer layer of the cortex is the glomerulosa that secretes mineralocorticoids like aldosterone. Inside that is the fasciculata that secretes glucocorticoids like cortisol. And then inside that is the reticularis that secretes androgens. Inside the cortex is the medulla that secretes catecholamines, things like norepinephrine, epinephrine, right? In normal physiology, from the hypothalamus, we create corticotrophic releasing hormone, CRH, that goes to the anterior pituitary. Anterior pituitary is stimulated, the corticotropes are stimulated, and they make ACTH, adrenal corticotrophic hormone. ACTH is cut from the same gene, the POMC gene, as alpha MSH. That'll come into play in a little bit later. ACTH then goes down to the zona fasciculata and upregulates production of cortisol. Cortisol has so many different roles. I can't cover all of them, right? But some of the bigger ones, right, it can increase sensitization of alpha 1 receptors. So we are more sensitive to norepinephrine, epinephrine. So we increase blood pressure. It causes insulin resistance, decreases insulin secretion, increases gluconeogenesis, so it raises our blood glucose. It causes apoptosis of a lot of different white blood cell types, right? Except for neutrophils or granulocytes, which it causes demarginalization and actually allows them to persist a little bit. So you might see low levels of eosinophils when they have really high cortisol, but you might see really high levels of neutrophils, right? And this is all, we're talking about the effects of cortisol here. And then we'll talk about the opposite in a second, which would be what this patient has. Other things cortisol can cause, right? Glaucoma, cataracts. It can cause bone weakness, so osteoporosis, osteopenia, avascular necrosis. It causes muscular atrophy, overall immunosuppression, weakening of the skin, like skin fragility, so you get abdominal striae. It causes weight gain, abdominal weight gain, moon phases, dorsal cervical hump if you have cortisol elevated for a really long time, amongst other things, right? So cortisol has so many different important roles. So you can think about it, when a patient has low cortisol, like an adrenal insufficiency, man, that can cause a lot of problems. And the biggest problems that we really worry about are, look, hey, if we're not sensitizing those alpha 1 receptors, we're really going to plummet that blood pressure, right? We're going to have leaky blood vessels. So their blood pressure can be low. Look at this, 98/67. We also are going to have quite low blood glucose, right? If cortisol, I just told you, cortisol is important for causing insulin resistance, decreasing insulin secretion, and gluconeogenesis, stimulating gluconeogenesis. So if we lose cortisol, we lose all those effects and the blood glucose can dip. So it's like the hypotension and the hypoglycemia are things that really stick out to me as like, okay, if I'm not treating this adrenal insufficiency, if I don't catch it, those are things that can lead to the patient dying, right? Um, so with regards to that, we then have to decide, all right, do we think this is primary or secondary adrenal insufficiency? And there are a couple things that can key me off, okay? So in primary adrenal insufficiency, the most common cause in America or in developed countries is going to be your autoimmune adrenalitis, okay? So that's what we call Addison's disease. It's classically autoantibodies against that 21 hydroxylase enzyme. All right, so it's very similar to the most common cause of congenital adrenal hyperplasia that you have probably learned about in your endocrine blocks. All right, so if I have autoimmune destruction of 21 hydroxylase, I can no longer make my glucocorticoids or my mineralocorticoids. So let's think about it, right? They're not making cortisol, their blood pressure is going to plummet, they're going to be hypoglycemic, right? If they don't have that cortisol effect, hey, maybe the eosinophils start to rise a little bit. We might see that. Cortisol also helps sensitize beta 1 receptors on my heart. So we might also see what's called a relative bradycardia. And in fact, we're kind of seeing it here in this patient, right? So their blood pressure is 98/67, which is, it's relatively low, right? I would expect their pulse to at least be around 100, if not higher. So this is what I call relative bradycardia, right? They're all, again, we talked about the blood glucose, so I'm already giving you that answer, right? The blood glucose would be low in both primary and secondary adrenal insufficiency, all right? Um, Other things cortisol does is cortisol inhibits the release of antidiuretic hormone from the posterior pituitary. So antidiuretic hormone is made in my supraoptic and paraventricular nuclei of the hypothalamus. It travels to the posterior pituitary and it sits there and it waits to get released. Remember, things that cause release of antidiuretic hormone are things like elevated sodium, right? So hypertonicity of my serum, low blood volume, and then pain, nausea, vomiting, okay? Um, so cortisol, when cortisol is elevated in the serum, it actually helps inhibit antidiuretic hormone. So when you lose cortisol, antidiuretic hormone, we have now taken the brake, we've taken our foot off the brake pedal, and we're able to just keep releasing antidiuretic hormone. Now, antidiuretic hormone does a number of things, right? It can go down throughout the body and bind to V1 receptors that are found on my endothelium, and that will lead to vasoconstriction, so it can raise blood pressure. You guys are probably all very familiar with its effect on the V2 receptors, which are found in the principal cells of my distal convoluted tubule and collecting duct. When ADH binds to the V2 receptors, it causes movement of the aquaporins, so we increase water reabsorption, so it leads to very concentrated urine, but then we dilute our serum, so that can lead to hyponatremia. And then antidiuretic hormone also can bind to the V3 receptors on my anterior pituitary that causes release of ACTH. But in this case, right, if cortisol is going to be low, and it's going to be low in both primary and secondary adrenal insufficiency, we're taking our foot off the brake pedal, we're allowing antidiuretic hormone to go sky freaking high, and the patient's going to be hyponatremic, okay? So it's very similar to SIADH, all right? So we've now got two answers for both primary and secondary adrenal insufficiency. Really, regardless, eventually these patients are going to be hyponatremic and hypoglycemic, right? So we're going to say their blood glue, right? This has been going on for 2 weeks. For sure by now, hyponatremic, hypoglycemic, all right? So continuing the talk on primary adrenal insufficiency, right? We're not just worried about cortisol here. We're also worried about aldosterone, our main mineralocorticoid. So remember, aldosterone, again, does a number of things. One of the big things it does is it upregulates or it stimulates the sodium potassium ATPases on your principal cells, right? And all in all, and then also the sodium hydrogen exchangers. So all in all, what it's going to do is it's going to keep sodium and water in your system, and it's going to kick out potassium and H+. So when aldosterone gets high, right, we keep sodium and water, so their blood pressure goes up, okay, blood volume, blood pressure goes up, and then we're kicking out potassium and H+, so you can become hypokalemic with metabolic alkalosis. So now if this patient had primary adrenal insufficiency, I'm not saying they do, we still got to decide that. If this patient had primary adrenal insufficiency, it would be the opposite, okay? So they're missing their aldosterone, or it's not working, we're not releasing as much, so less sodium and water being reabsorbed, so their blood pressure is going to be on the lower side, all right? And then we're not able to kick out potassium and H+ as well, so they might be hyperkalemic, and they might have metabolic acidosis. And this would be an example of non-anion gap metabolic acidosis. So their anion gap, sodium minus bicarb plus chloride, will be somewhere, I consider an elevated anion gap is going to be, 12 to 14 above that level, right? So their anion gap should be normal, all right? So though that would be what I would expect for primary adrenal insufficiency. And we discussed autoimmune adrenalitis as the most common cause in developed countries. In developing countries, it's tuberculosis adrenalitis is the most common cause. So infection of tuberculosis infection in the adrenal gland itself can cause destruction that way. Another very high yield concept for you guys to know is something called Waterhouse-Friderichsen syndrome, which is secondary to disseminated meningococcal disease. So Neisseria meningitidis, a gram-negative diplococci that gets systemic, and it actually can cause hemorrhage of the adrenal glands itself, and that can lead to primary adrenal insufficiency. So in that patient, you might see purpura or petechiae secondary to DIC. They might have a high fever. They might have signs and symptoms of meningitis, right? That's kind of how you're going to get keyed into that on a vignette or in real life, all right? So that's primary adrenal insufficiency. Now, secondary adrenal insufficiency is going to be a problem up in my pituitary itself, right? Or if you want to consider it, right, if we're grouping secondary and tertiary together, for this case, hypothalamus or anterior pituitary. But regardless, right, in this case, we're going to have a hard time making or secreting ACTH, all right? So in this patient, right, I'm going to tell you, this patient likely has secondary adrenal insufficiency, all right? So she has polymyositis, right? So remember, polymyositis is an autoimmune destruction, usually of my proximal muscles, okay? Without the skin manifestations of dermatomyositis. So she's not going to have heliotrope rash. She's not going to have Schall's-Heim. She's not going to have Gottram papules, all right? One of the mainstay treatments for a lot of autoimmune conditions is steroids, right? So she's been on steroids. Likely, I don't think I told you how long, but she's been on steroids, let's say, for a decent period of time. And so she's essentially taking exogenous cortisol. So as she takes exogenous cortisol, it feeds back and it tells the hypothalamus and anterior pituitary, hey, we don't need to make CRH. We don't need to make ACTH. We're getting all the cortisol we need, all the glucocorticoids from this pill. So you stop making ACTH, all right? So there's less ACTH going down to the adrenal glands, and ACTH is adrenal corticotrophic hormone. So if we're not getting that trophic effect, the adrenal glands slowly start to atrophy, all right? So now all of a sudden, right, we classically see secondary adrenal insufficiency when a patient has been on like long-term steroids and then all of a sudden stops them without doing a long-term taper. And so this patient has been very sporadic with her medication use. So all of a sudden, she went from her body just relying on these exogenous steroids to now, oh crap, she doesn't have any of them. And guess what? The adrenal glands themselves, they kick back into play, decently like soon. But it takes the anterior pituitary a decent amount of time to kind of, kick back in, okay? So now she stopped taking the cortisol, all right? And her anterior pituitary is still, offline. And so she has no stimulus going down to tell the zona fasciculata, make more cortisol. So this woman now is not taking her cortisol, and she's no longer getting the stimulus for her adrenal glands to make her own endogenous cortisol. So she is missing her glucocorticoid. Now, notice what I said. She is not missing her mineralocorticoid, right? Her mineralocorticoid, the zona glomerulosa, responds to angiotensin 2 from the renin-angiotensin system and hyperkalemia, right? Those are the two main stimuli for aldosterone release. Ang2 and hyperkalemia, right? The hyperkalemia should make sense, right? Aldosterone kicks out potassium, so elevated potassium should stimulate it, right? So in patients with secondary adrenal insufficiency, their mineralocorticoid levels are usually quite normal, and aldosterone in this patient should be secreted as per usual. And so aldosterone is going to help regulate the potassium and bicarb levels, right? So this patient's potassium and bicarb should be within normal limits. Now, if this was primary adrenal insufficiency and we're missing the aldosterone as well, well, guess what? Now we can't kick out potassium. The potassium starts to rise, so that's elevated. I can't kick out the H+, so the H+ starts to rise and the bicarb would be low, right? But this is an example of secondary adrenal insufficiency. The key point, I cannot stress this enough. Secondary adrenal insufficiency, their zona glomerulosa is still able to secrete mineralocorticoids because those are not driven by ACTH. They are driven by Ang2 and potassium are the main things, right? So her bicarb, her potassium should be normal. Her sodium will likely still be low because her cortisol is low. So there's a lack of inhibition on antidiuretic hormone, okay? And her glucose should be low because she has a lack of cortisol, right? So she doesn't have the insulin resistance, the blockage of insulin, and she's not stimulating gluconeogenesis. Now, the last piece of the puzzle, right? You might read in questions, for a patient who has primary adrenal insufficiency that's been going on for a little bit of time, they might be hyperpigmented, right? So classically in like the lines of the palms, okay, subareolar areas, and then mucosal surfaces. So around, the mucosa of the mouth, and then in females, the vaginal tract are areas that if you're suspicious, you can ask or look, right? Depending on the scenario you're in. The reason you can get hyperpigmentation is ACTH is cleaved from that POMC gene that also makes alpha MSH, okay? Alpha MSH is definitely going to cause hyperpigmentation in high amounts, and there's actually data to suggest in high amounts ACTH can also cause hyperpigmentation as well. A patient with secondary adrenal insufficiency, well, in this case, they're not making any ACTH, right? So if they're not making ACTH, they're not cleaving that POMC gene, their ACTH is low, and guess what? So is their alpha MSH. So they're not going to be hyperpigmented. We're not going to talk about hypercortisolism in this lecture, but hypercortisolism, either Cushing syndrome, Cushing disease, right, is going to be the exact opposite. If you think about it, if they have Cushing disease or they have an ectopic source of ACTH, whether it be small cell lung cancer, carcinoid tumor, or some of the common examples, those are also making elevated ACTH. So whenever you're making elevated ACTH, it's got to come from that POMC gene. So with the ACTH and the alpha MSH, patients with primary, with Cushing disease, which is an ACTH secreting tumor, or the ectopic ACTH production, they may also be hyperpigmented, right? So very long-winded answer. It's all here if you want to take a screenshot. And again, this is like everything I said, kind of very, very summarized. But again, the sodium decrease, potassium bicarb should be normal, glucose decrease. The key point in this, we have to understand primary versus secondary. I guess I forgot to discuss this last part. Concentropin is ACTH, okay? So in both primary and secondary adrenal insufficiency, your morning serum cortisol should be low, right? Remember, cortisol usually starts to rise in the morning. The key thing, one of our endocrine professors always said, if you suspect the hormone is low, you should check it when it should be high. And if you suspect the hormone is high, you should check it when it should be low. So in this case, we have a suspicion of adrenal insufficiency. We have a suspicion that the hormone should be low. So we're going to check it when it should be high, which is in the morning. So her serum cortisol is low, and so is the ACTH. So that right there already is keying me in that this is likely secondary adrenal insufficiency. Because in primary adrenal insufficiency, her cortisol would be low. there would be less or no negative feedback back to the anterior pituitary, and their ACTH should be pretty high, right? Sky freaking high. Um, so that keys me in. But then we give her cosyntropin. We give this patient the ACTH that they've been missing, and all of a sudden her cortisol increases, right? Because all we're doing for this patient is we're giving them the hormone they've been missing. But if this patient had primary adrenal insufficiency, I could give them all the ACTH in the world. And if they have destruction of their adrenal gland, of their zona fasciculata, or of that 21 beta hydroxylase, it really does not matter how much ACTH I give them. Their adrenal gland's just not going to be able to respond. And hey, maybe the cortisol goes up a little bit, but it ain't going to increase by a lot. And so they'll on a board exam, they will be very clear cut with you, like the cortisol does not rise, right? In real life, it's definitely a lot more complex than that. And that's why you consult an endocrinologist who's an expert in this stuff, right? Treatment is kind of beyond the scope of step one, but obviously in adrenal insufficiency, we're going to want to replace the hormones they're missing. So in secondary, for sure, we're going to give them some sort of cortisol, right? Some sort of glucocorticoid. It tends to be hydrocortisone. Hydrocortisone has both mineralocorticoid and glucocorticoid properties. And then in primary adrenal insufficiency, hey, we might also have to give them a little bit of fludrocortisone, which is a straight up mineralocorticoid. All right. And then obviously if they have tuberculosis or Neisseria meningitis, we have to treat those effectively. So there's that answer. Again, take a screenshot if you need, and we'll move on. The key with this, I promise you on every MBME exam you're going to take for the rest of your life, you will probably get, if not one, multiple questions on adrenal pathology, whether it be hypercortisolism or adrenal insufficiency or congenital adrenal hyperplasia. So these are things you really got to know and really got to sit there and think about these pathways. All right. So let's move on to the next one. 45-year-old female presents to the ED with complaints for 2 days of relentless palpitations and dyspnea. She has never felt these symptoms before and is quite scared. You note in her history that she's originally from Bangladesh and immigrated to America at the age of 20. She notes that she has been relatively healthy, but was hospitalized at the age of 10 for severe joint pain in her ankles and wrists and odd movements of her face. She remembers being placed on an antibiotic for quite some time after this. Her vitals are notable for a heart rate of 150, blood pressure is 130/85, her temp's 98.8. After gathering history, you perform an EKG that I showed below, a rhythm strip, and an echo I also showed below. How do you explain the pathophysiology of this patient's current presentation, and what murmurs should we expect to hear on cardiac auscultation? Okay, so pause your screen and consider, and then we'll discuss. All right, so in this case, I've got a patient whose clinical history sounds quite familiar or sounds consistent with rheumatic fever, okay? What's kind of bringing me to that conclusion? Well, I see already, right, when I'm looking at my data, I'm seeing it looks like we've got atrial fibrillation in this rhythm strip, right? I've got nice narrow QRSs, okay? They're irregularly irregular, and I'm not seeing definitive P waves before the QRS or QRSs after the P waves. Instead, I'm seeing these fibrillation waves, okay? I'm then looking at this echo, and really, if you are a student preparing to take step one or even step two, I don't expect you to be great at reading EKGs, CT scans, or echoes, right? Things like that. Like this is stuff that takes years and years and years of practice. And in fact, there's a whole residency if you want to become a radiologist, right? Where you become experts at this. Myself, about to start intern year, I still need a lot of practice and a lot of help reading some of these advanced imaging things, right? But when I'm looking at this echo, this guy right here in the view we're in, this is the left ventricle, this is the right ventricle, this is the left atria, and this is the right atria. So her left atria is massively enlarged, right? So I've got atrial fibrillation, I've got a massively dilated and enlarged left atria, and then we go back to our patient, right? She's got the palpitations and the dyspnea. Well, that might be explained by the atrial fibrillation. We also see, hey, she's coming from a place where, in a vignette or in real life, you hear someone coming from a third world country. You don't want to assume, but like this is what the test writers are doing, is they're saying, hey, she's from a place where they likely aren't getting, the best healthcare, right? They just don't have the resources we do here in America. So that's kind of what they're getting at is, okay, this patient maybe comes from an area where some of her past medical history, like things she's dealt with, maybe she didn't get the best medical care, the most appropriate. Um, we also note, right, she's been relatively healthy, but a while ago, she had a history of joint pain in the ankles and wrists and odd movements in the face, right? So if we think about rheumatic fever, all right, so now I'm kind of putting it together, right? We've got atrial fibrillation, left atrial enlargement. She has this history of joint pain, odd movements in the face, right? She's from an area where she's not getting maybe the best health care. And then she was placed on an antibiotic for quite some time after this, right? That's enough there for me to, kind of integrate the material together to think about rheumatic fever. All right. So when I think about rheumatic fever, really quickly discussing the pathophysiology, we think about the pathophysiology would be a group A strep infection. It's classically of the pharynx, okay? Group A strep, a gram-positive cocci in chains, beta hemolytic, right? It classically needs to impact the pharynx because that will elicit a strong enough immune response that can predispose to rheumatic fever, all right? Group A strep has something called M protein on its capsule. Our immune system ends up making antibodies against that M protein. Unfortunately, that M protein looks a lot like the myosin that's found in my cardiac tissue, especially around the mitral valve and the aortic valve. Okay, so these antibodies end up taking care of the pharyngitis, the pharynx infection. But then the antibodies are like, yo, what do we do now? And then it starts to sense, hey, we can go attack this myosin, right? We're built to also attack the myosin. And they do, right? So early on, a lot of that inflammation around the mitral and the aortic valve can lead to regurgitation, right? But over time, all that inflammation and damage leads to fibrosis, and then we get stenosis, right? So the mnemonic I always teach my students is ARCS, ARCS, acute regurgitation, chronic stenosis. Well, this patient had rheumatic fever, several years ago, right? So she's probably at the point of having stenosis, right? And the most impacted valve would be the mitral valve, with aortic being second. All right. So that's rheumatic fever. Now, to stop rheumatic fever, if we give the patient penicillin or amoxicillin, which are appropriate treatments for a group A strep, and they take the full dose, that's usually enough to mitigate any risk for rheumatic fever. Now, this is opposite to post-streptococcal glomerulonephritis, where even if I treat them appropriately with antibiotics, there's still a risk they may progress to PSGM, which is not a type 2 hypersensitivity like rheumatic fever, but rather a type 3 where we get immune complex deposition into the glomerulus itself. For rheumatic fever, it has to be a pharynx infection. It has to be pharyngitis. The skin infections, things like impetigo or sepsis, cellulitis, are not going to elicit a strong enough immune response to stimulate this rheumatic fever. In PSGN, it could be either pharynx infection or a skin infection. All right. So if we're assuming, and then the last piece, right, with regards to rheumatic fever, other symptoms, right, we think about our Jones criteria. So the J stands for joint pain, right? We classically get migratory joint pain. So maybe it starts in the ankles and moves up to the knees, moves up to the wrists, to the fingers, right? It's moving, it's migratory. The O is it kind of looks like a heart. So that's the carditis, right? So chest pain, and then all the cardiac manifestations, some of which we've talked about. The N are subcutaneous nodules. The E is erythema marginatum, which are serpiginous kind of rashes around the body. Don't get them confused with erythema chronica migrans, which is the annular bullseye rash we see in Lyme's disease. I'm sorry I don't have a picture of erythema marginatum, but you can easily look them up quick. It's like very, it almost looks like tinea. It's very serpiginous rash that you may notice. And then the S is Sydenham chorea, where these autoantibodies are also now attacking the basal ganglia. The basal ganglia are really important for fine movements, a lot of the limbs and my face. So the basal ganglia is also what's impacted in Huntington's disease. And so if you think about your classic illness script of Huntington's disease, these patients often have facial tics and movement disorders. So it can present very similar to that as well. We usually put these patients on long-term penicillin prophylaxis because we're trying to prevent a future group A strep infection, because if they get another group A strep infection, they're at risk for really exacerbating their cardiac disease. Okay. So I put all of that together and I'm like, yeah, this sounds like rheumatic fever. Okay. So then we got to think about, right? I'm asking you about the pathophys. We already talked about the pathophys of rheumatic fever itself. And now we're like, okay, we kind of came to the conclusion that this patient probably has mitral valve fibrosis at this point, and therefore mitral stenosis likely, right? So when you think about mitral stenosis, we've now got a really rusty valve that's blocking the left atria from the left ventricle. So the left atria is relatively low pressure. Now all of a sudden it's got to really build up a lot of pressure to bust open that rusty door during diastole to move fluid, to move blood from the left atria to the left ventricle. All right. So the left atria, it's going to have to work harder. It's going to have to hypertrophy. And that pressure is just going to build up, build. And that pressure is going to cause stretching and dilation of that left atria. As that left atria stretches and dilates over time, it stretches on my electrical conduction pathways and it distorts the electrical conduction pathways in the left atria, classically around the area of the pulmonary valve, and it can lead to distortion of this electrical conduction pathway, can lead to ectopic atrial foci that are just firing off at will, leading to atrial fibrillation, right? So that is essentially kind of putting the pieces together. And then my last question is, what murmur should we expect to hear? Well, we've already decided mitral stenosis, okay? So that's exactly how MBME is probably going to ask you this. You know, they're going to give you some long-winded vignette, and you're going to read right off the bat. You're going to be like, hey, Adam taught me everything about this. This sounds like rheumatic fever. And they're going to ask you, what would we hear in cardiac auscultation? Maybe they'll be nice to you, and they'll just say aortic regurg, aortic stenosis, pulmonary stenosis, blah, blah, blah. And you'd pick mitral stenosis if in the right circumstance, right? Remember, acute regurg, chronic stenosis, okay? But you just remember mitral is the most commonly implicated. And we kind of go from there. You got to use your context clues. I'm not giving you just like a one size fits all. Or they would be a little bit meaner and describe your murmurs. And so mitral stenosis is classically an opening snap followed by a diastolic rumble. So remember, between S1 and S2 is systole, between S2 and S1 is diastole. So between S2 and S1, the mitral valve should be snapping open to allow blood to flow from the left atria to the left ventricle. But because this is a stenotic valve, right, we're going to end up hearing that murmur during diastole when that stenotic valve slowly opens up, right, due to the rust of the fibrosis of this valve. So that's kind of how you put this clinical picture together. Treatment for AFib is kind of beyond the scope again for step one, but this patient is hemodynamically stable, so we can choose rate or rhythm control. Rhythm or rate control would be things like a beta blocker, so metoprolol tends to be the go-to, or a calcium channel blocker, so like diltiazem tends to be the go-to calcium channel blocker. Examples of rhythm control would be things like flecainide, propafenone, amiodarone, digoxin, or even direct cardioversion. If this patient were hemodynamically unstable, so systolic blood pressure less than 90, we would likely do direct cardioversion right off the bat. Treatment for AFib is a lot more complex than that. Those are just like kind of the bare bones, right? So you'll learn more details as you go through step 2, step 3, and your residency. All right. Next one, we've got two more. 65-year-old male with a past medical history of heavy alcohol use presents to the ED for confusion and a nosebleed that will not stop. His vitals are notable for a blood pressure of 145/65, heart rate of 105, temp of 99. On exam, his abdomen is protuberant with a fluid wave shift. He has reddening of his palms bilaterally and several small blanchable telangiectasias scattered around his chest. Labs are notable for a platelet count of 70,000, a BUN of 50, and creatinine of 2.1. Both of those kidney functions are way above his baseline. So I've got a couple questions for you. We'll hit them one by one. So first, think about how should we rule out spontaneous bacterial peritonitis in this patient? So pause your screen and consider. All right, so this patient surely has liver cirrhosis, okay? The diagnosis of liver cirrhosis is beyond the scope of step one. We often can use what's called the FIB-4 score, where we take multiple different lab values together. We can do elastography, which is one of the gold standard imaging. We can do a fibrosis scan, or the absolute gold standard that we rarely do, would be a liver biopsy itself, right? But we see, right, he has the heavy alcohol use, absolutely can progress to alcoholic cirrhosis. And then we see some of the cutaneous signs and symptoms of cirrhosis itself, such as reddening of the palms, right, secondary to hyperestrogenism. Telangiectasias, also secondary to hyperestrogenism. Maybe we would see gynecomastia. We could see ascites, secondary to portal hypertension, right? Maybe the patient, if we did a testicular exam, he would have small testes potentially, right? These are all some of the things you can see. You can also look at nails, and you can see potentially Terry's nails, where about 10% of the distal portion of the nail is going to be very reddened compared to the proximal portion will be more white. Okay. So these are all things that kind of point us into, okay, maybe they do have cirrhosis, right? So spontaneous bacterial peritonitis. We have so many different bugs, right? Our microbiome, like trillions of bugs living in our gut. A lot of them, right, are going to be filtered through the liver at some point because we have this massive portal vein and the hepatic artery bringing blood through the liver. The liver has a really good immunological function to kind of filter out and kind of remove some of these pathogens. The problem is when you have liver damage, the liver can't do that as well, right? So a lot of these pathogens can persist. And then we think about on top of it, all right, if they have liver cirrhosis, they have a hard time breaking down vasodilatory molecules. The most well-studied one is probably nitric oxide, right? You've probably read about this in questions or in your reading. But nitric oxide levels tend to be elevated in liver cirrhosis, and that can cause vasodilation of vessels, vasoplegia. And when these vessels get very dilated, it allows these pathogens to translocate from the gut into the peritoneum. And now they're in the space they shouldn't be. And on top of it, patients with cirrhosis often have ascites. Okay, so there's a lot of fluid in there, and these pathogens just persist. They love living in the fluid, right? And then they can cause a lot of inflammation, okay? Inflammation and then an ultimate infection, right? When the immune system responds. So peritoneal signs are what we consider a very hard abdomen, right? Rebound tenderness, I press down, and then when I let go, it really hurts. They have guarding, they're not going to let me touch. And then so those are some of the signs. A high fever, right? You got to be careful with the fever though, because patients with liver cirrhosis have a very dampened immune system, like I said, so they're maybe not able to mount a normal fever, like say you or I with normal physiology. So don't always just be like, hey, they don't have a fever, there's no infection, right? So any patient with ascites who presents to your hospital, unless they have some weird circumstance going on, they should get a paracentesis, okay? In that paracentesis, you're going to send off a lot of different lab values, but the one to rule out spontaneous bacterial peritonitis, we want to look at the cell count with differential, all right? If that cell count with differential shows less than 250 polymorphonuclear cells, it's not SBP. If it's above 250, we diagnose them with SBP, all right, spontaneous bacterial peritonitis. I don't care. You're also going to order a gram stain. I do not care if that gram stain comes back positive or negative. If the PMNs are above 250, you've got your diagnosis of SBP, all right? So if it's above 250, if the patient's coming from the community, we start them on an IV third-generation cephalosporin. Something like ceftriaxone is usually a good option, all right? That's SBP, one of the highest yield concepts, step 1, step 2, step 3, all right? All right. You suspect that this patient's confusion, thrombocytopenia, and mucocutaneous bleeding, and AKI are all likely a result of his intrinsic liver disease. I want you to propose a mechanism for each of his symptoms secondary to his liver disease. So pause your screen and consider, and we'll discuss. All right, so we'll start with his confusion first, right? I have my kind of schema for confusion or altered mental status is mist, metabolic, infectious, structural, and toxin. With infections, I also throw in like immunological, right? Eye infection and immunological as well. So really in real life, you should systematically go through each of those and rule out other stuff before you just blame it on his liver disease, right? Ultimately, what I'm getting at is hepatic encephalopathy, right? So it's one thing, like I've especially seen a lot of medical students that I've worked with, when they lay out a vignette like this, you're like, no shit, they're getting at hepatic encephalopathy, right? But in real life, it's not that simple. And sometimes on vignettes, they know students are going to jump to hepatic encephalopathy, and they throw something else in the vignette that actually should point you somewhere else, right? But in this case, right, I want you to think about the pathophysiology of hepatic encephalopathy. So in hepatic encephalopathy, right, we have damage to the liver for whatever reason, right? In this case, alcoholic destruction of the liver leading to a fibrotic nodular liver, right? We have our urea cycle located in the liver. That's really important to convert ammonia into urea, and then urea we can pee out, right? So in this case, if that whole urea cycle, all those enzymes are getting destroyed because of the liver damage, we're no longer able to effectively and efficiently convert ammonia into urea. So ammonia starts building up. Ammonia, NH3. NH3 ammonia can cross the blood-brain barrier. It can get taken up by astrocytes. It then gets metabolized to glutamine. Glutamine is very osmotically active, so it draws water into these astrocytes. The astrocytes swell and they start compressing the brain, right? And as we compress the brain, it can no longer work effectively and efficiently, and then we get altered mental status, right? So with regards to hepatic encephalopathy, how do we go about treating it, right? Well, first off, hepatic encephalopathy is a clinical diagnosis. You probably learned about asteresis, where you can have the patient extend their hands against gravity, and then you can put a little pressure on it, and they'll kind of bounce back and forth, almost like clonus of the ankles that you've learned about in some of these upper motor neuron lesions. Asterisks is by no means specific. I could see it in other neurological conditions. I can even see it in elevated uremia, okay, and kidney disease. So that's one thing you might look for. You probably learned about, you can get serum ammonia levels. Serum ammonia levels do not correlate with hepatic encephalopathy at all. There could be patients with really bad hepatic encephalopathy who have normal ammonia, and there can be patients with sky-high ammonia who are totally A&O times 4, alert and oriented times 4. They know person, place, why they're there, etc. Right? So I don't really you can use the serum ammonia kind of periodically to see, hey, is it going down? Is this doing anything? But a lot of clinicians aren't really using it because it hasn't shown to kind of have that correlation we would like it to. So it's a clinical diagnosis, and to start treating them, we usually start with lactulose. We give lactulose by mouth usually. It then gets chewed up by lactobacilli in the gut. That ends up with the metabolism of it, makes H plus hydrogen, okay, hydrogen ions. That hydrogen ions acidifies the gut and can actually kill off some of these ammonia producing bacteria. The hydrogen in the gut then binds to the NH3, makes NH4, which is non-absorbable, and we poop it out. And then the lactulose itself is a cathartic laxative, which also helps poop out some of this ammonium, right? So ammonium is NH4 plus. That's how lactulose looks. You can also add rifaximin if needed, which is an old antibiotic that kills off some of these ammonia-producing bacteria. All right. So then for the thrombocytopenia, there's two major mechanisms for thrombocytopenia in liver disease, right? Again, this patient might have other things going on, so we don't want to just hedge our bets on it's the liver disease, but this is what I'm trying to get at, right? So there's a hormone that's very similar to erythropoietin in the kidney that stimulates platelet function, right, or platelet stimulation, right? So erythropoietin in the kidney, made in the peritubular fibroblast, goes over to the bone marrow and stimulates reticulocyte production to make more red blood cells. Where there's something in the liver called thrombopoietin that does the same thing. It goes to the bone marrow and it stimulates megakaryocytes, so then we produce more immature platelets and eventually mature them to platelets, right? So when you have intrinsic liver disease, we can no longer make the thrombopoietin as effectively and efficiently, and intrinsic platelet maturation decreases, right? Another thing that happens in liver cirrhosis, we got a really hard nodular liver. I think about it like a brick wall, okay? We've got this massive portal vein shooting into a brick wall. Well, a lot of that fluid's not going to get through, so it's going to back up. We're going to get portal hypertension, right? The pressure in the portal vein starts increasing and increasing and increasing so we can move through this brick wall. Well, eventually, right, that fluid's going to keep moving back. The hydrostatic pressure is going to keep increasing, and we're going to keep moving back until we get to the level of the spleen. And now the spleen is going to, I think about the spleen like a sponge. The spleen's just going to get bigger and bigger and bigger and more congested. And what does the spleen do? Spleen's really good for recycling pathogens, recycling our immune cells, right? White blood cells, red blood cells, platelets. Well, our platelets can also get stuck in the spleen itself. So the two major mechanisms would be splenic sequestration and then a lack of thrombopoietin, okay? Secondary to the liver disease itself, all right? And then the AKI, right, if we do the math, 50 divided by 2.1 is somewhere around like 24, 25, right? So it's likely a pre-renal, right? There's a certain algorithm we have to do to diagnose hepatorenal syndrome, which is kind of a story for another day. That's more of a step 2, step 3 concept, so I don't expect you to know that for step 1 level of understanding. But in this case, right, it's essentially what I discussed earlier. When we have elevated vasodilatory molecules, they cause vasodilation of my splanchnic vessels. So those are the veins in the mesentery, the gut, that is going to end up draining into the liver. So we're going to cause vasodilation of that. And a lot of this blood is just going to now pool in these vessels, okay? Splanchnic vasodilation, blood pools in the vessels. So now there's less blood moving back to the right atrium or to the, in fact, the SVC, the IVC, right? In this case, the IVC, because it's going to be drained from the hepatic vein. So there's less blood making its way back to the right side of the heart, less blood making it through the lungs, less blood to the left side of the heart, and then less forward flow out to the system, okay? Kidneys are not going to like that, right? Kidneys get 25% of your cardiac output. And so if it's not getting the blood supply it needs, that glomerular filtration rate dips down, right? It starts, man, the kidneys are going to start failing pretty quick, right? And so if the kidneys aren't able to work as effectively and efficiently, we can no longer reabsorb, or we can no longer excrete the urea, the nitrogen, and the creatinine. So their BUN starts to rise, and so does their creatinine, all right? So that's kind of the way you want to think about that. And again, hepatorenal, we won't kind of discuss that now because it's a very kind of complex advanced algorithm on top of that we don't need to go into for step 1 stuff. And then my last question, if we got a coagulation study on this patient and we got his PT and PTT and we saw that they were elevated as well, which they very well might be in this patient, how could we best decide if this were due to his intrinsic liver disease or due to DIC? So pause your screen and consider that. All right, so in intrinsic liver disease, right, all of my clotting factors except for factor 8 are made in the liver. Factor 8 is made in the endothelium, right? So in a patient who's got pretty significant liver disease, well, we're not really making a lot of our clotting factors as effectively and efficiently as we should, right? So of course, the PT and the PTT will surely start to rise, right? So they're at risk for hemorrhage, right? Because they are losing the ability to clot, right? We talked about, hey, their platelets might be low, so they're also missing that aspect as well, their primary hemostasis. On the contrary, though, what else is made in the liver are things like fibrinogen, things like protein S, protein C, antithrombin 3. So if you're missing those, well, now they're going to have the exact opposite problem. They're at risk for thrombosis. So you think about a patient with advanced liver disease, they're like on a seesaw, you know, they get pushed in one, like a little bit in the one direction, they hemorrhage out. They get pushed in one direction, they stroke out, right? They have a thrombosis somewhere. So it's very like hit or miss on what could happen to these patients. Then we consider DIC, a consumptive coagulopathy. It's secondary to something major. It's sepsis, pancreatitis, ARDS, cancer, etc. that causes an overactivation of platelets and clotting factors. So then we get clots everywhere, but then we use everything up. So then the patient starts bleeding out. And so you look at this patient, right, the vignette I gave you, hey, he's got a nosebleed that's not stopping, okay? And if I told you he had an elevated PT and PTT, well, you got to consider DIC, right? So In DIC, I would see an elevated PTT. I would see an elevated D-dimer or breakdown products of fibrin because we're laying down all these fibrin sheaths and then cutting them up, right? I would also see a low fibrinogen because fibrinogen is converted to fibrin. So, of course, we have to use up all of our fibrinogen. And then I would see low platelets, right, because we're using them all. But guess what? You could absolutely see the exact same things in advanced liver disease. Okay, the PTT because we're losing all of our clotting factors except for factor VIII. The low platelets, again, because of the mechanisms we talked about. Fibrinogen is a protein that's made in the liver. So if the liver ain't working, we're not going to be making fibrinogen as well. And then, of course, the D-dimer, right? If we're making clots and stuff, or just all the inflammation itself, of course, a D-dimer could be elevated. So it's very hard to tell the difference. So truly, if this patient comes in and we see a low fibrinogen, less than like 150 or 100, we're probably just going to treat them exactly the same, whether it be intrinsic liver disease or DIC. We're going to give them cryoprecipitate, maybe FFP, right? And then we're going to try to figure out the underlying cause, right? So if you've kind of caught on to what I've said, I keep mentioning all the clotting factors are made in the liver except for factor VIII. So why don't we use that understanding of physiology, that mastery of the physiology to our benefit, right? So I can go off and I can send factor VIII levels. Now, those aren't going to come back immediately. They might take a little bit of time. So again, it doesn't change our immediate intervention, but it can help us in about a day when we get the lab value back and we can be like, oh, this was liver disease. We got to go down this route. Or, oh, this was DIC. Do we need to work him up for cancer? Did he have something else going on, right? So it helps us down the line. So if this were DIC that's causing the presentation, the factor VIII level should be low, right? It's a consumptive coagulopathy. The DIC is just going to use up every clotting factor. It doesn't matter where it's made, all right? But in liver disease, we're only going to be missing the clotting factors that are made in the liver. Factor VIII is made in the endothelium, okay, so it shouldn't be impacted. So the factor VIII level is either normal or, in fact, sometimes it can be elevated because it is considered an acute phase reactant. All right, so that's kind of how you can tell them apart. I've talked about this concept before, but I think it's worth mentioning again. All right, so there's all that. Again, really long explanation. So please screenshot. It's literally everything I mentioned, but screenshot if you need, and then we'll move on. And I don't know if I gave you enough time here, but you can screenshot for that rheumatic fever one as well. All right, and then we're going to the last one. This one will be relatively quick. We have a 70-year-old male is recently diagnosed with non-Hodgkin's lymphoma. He started on appropriate chemotherapy. 2 days later, he presents to the ED with complaints of fatigue, weakness, and palpitation. So my first questions for you, with regards to phosphate, potassium, calcium, and uric acid, would these values be expected to be elevated or decreased? So we've got the brief vignette I gave you, and now with this first question, I'm already telling you there's something going on with his electrolytes. So you've got this patient with non-Hodgkin's lymphoma, recently started on chemo, coming in with fatigue, weakness, palpitations, and now I'm telling you there's something up with his phosphate, potassium, calcium, uric acid. I want you to pause your screen and tell me, would they be elevated or decreased, right? They could be different for each one. So go through each electrolyte or each molecule and tell me elevated or decreased. So pause your screen and consider. All right, so hopefully you caught on that this is likely tumor lysis syndrome. Tumor lysis syndrome happens usually secondary to leukemias and lymphomas with either really high tumor burden or right after chemotherapy or like shortly after chemotherapy. So it's classically a blood cancer with high tumor burden or recent chemotherapy, all right? All tumor lysis syndrome is, it's exactly what it sounds like. We are lysing all these cancer cells and releasing all the inner products, right? So cells have a lot of calcium, phosphate, potassium, uric acid, lactate dehydrogenase, etc., right? These are all going to get dumped, right? So with regards to these, right, phosphate should be high, potassium should be high, uric acid should be high, but calcium actually tends to be low, right? So the calcium tends to be low because some of the phosphate will bind to it in the gut, but then calcium also likes to deposit into different organs, especially the kidneys. So a lot of the free calcium is going to be bound up in organs as well. So the calcium is going to end up being low. So in tumor lysis syndrome, the phosphate, potassium, uric acid are elevated, and the calcium tends to be low. For the sake of step 1, you don't need to know cutoffs, but for step 2 and beyond, you should know the Cairo-Bishop criteria, which states you need 2 out of the 3. You need the phosphate to be above 4.5, the potassium to be above 6, the calcium to be below 7, and the uric acid to be above 8. If you have 2 out of the 3 in the right clinical scenario, you can diagnose tumor lysis syndrome. We can also clinically diagnose it with a creatinine greater than 1.5, the patient's having arrhythmias, or the patient's having a seizure. All right. So that's tumor lysis syndrome. All right. Next question. Was there anything we could have done beforehand to help mitigate this patient's current pathology? So pause your screen and consider. So prophylaxis for tumor lysis syndrome is IV fluids. IV fluids is the best thing we can do. We give it a lot before and during chemotherapy to help prevent this tumor lysis syndrome. We could also pre-treat with allopurinol, which is a xanthine oxidase inhibitor. Okay, that would obviously help us reduce uric acid production, and the uric acid can be very damaging to the kidneys. So this is a good thing. But if we, for some reason, we don't do this, right, and the patient ends up developing tumor lysis syndrome, I can't treat them with allopurinol acutely while they already have elevated uric acid, because allopurinol blocks xanthine oxidase, and their uric acid is already sky high. And in fact, giving them allopurinol can actually cause an exacerbation, an elevation of uric acid. It can perturb us in the other way. So allopurinol is not going to do anything, and if anything, it might actually make things a little bit worse. So what we do when the patient already has tumor lysis syndrome is I can give them rasburicase. Rasburicase is an enzyme that chews up uric acid. It's uricase. You got to watch out. Rasburicase can trigger G6P deficiency. It can trigger hemolytic anemia. So we like to test for that beforehand. Again, more of maybe a step 2, step 3 concept, but I like to teach you guys this stuff beforehand. Next question. How do we go about treating hyperkalemia that's causing cardiac issues? So pause your screen and consider. So hyperkalemia can do a lot of things to the heart. Obviously send us into an arrhythmia, eventually ventricular fibrillation, where if we don't do unsynchronized cardioversion, the patient's going to die, right? On an EKG, you can see peak T waves, we can see widening of the QRS, and then we can eventually see sine waves and then ventricular fibrillation. You all are probably familiar with the peak T waves. So if the patient has an elevated potassium and you get an EKG and their T waves are peaked, you're like, oh crap, we got to act, right? First thing you do is you give them calcium, okay? So I can give them calcium gluconate from a peripheral IV, or I can give them calcium chloride from a central IV. Calcium chloride has a lot more calcium in it, but it can only be given via central IV because it's very aggravating. It's very essentially caustic if we give it via peripheral IV, whereas calcium gluconate, less overall calcium, and it's easier to give through a peripheral IV. The data on giving calcium to stabilize the cardiac membrane isn't great. It's kind of one of those things we do for no reason, but it's always the right answer on a board exam. Because obviously if we give calcium, the theory is we're increasing the amount of calcium coming through that phase, through that plateau phase in the cardiac action potential that can help stabilize that cardiac membrane. So really, if the patient has hyperkalemia and in the vignette they haven't done anything to the patient, the first thing you always do is give calcium. You don't do dialysis, you don't do anything else, you give them calcium. That's always the right answer as of right now. All right. Then, so we've stabilized the cardiac membrane. Next thing we need to do is we need to drive potassium into the cells. The best thing we got for that is give them insulin. So insulin upregulates sodium potassium ATPase, which will drive potassium into the cell. Obviously, if we're giving them a lot of insulin, they're going to become hypoglycemic. So you also give them dextrose as well. We could give them a beta-2 agonist like albuterol. We could give them bicarb, which also will end up driving potassium into cells. But you got to give so much albuterol and so much bicarb that it ends up causing a lot of side effects. So we don't really do those. It's usually insulin and dextrose is the mainstay. And then the third tier is, hey, we got to remove any excess potassium that's still in the system. So I can give what's called K-exalate, which is a chelator of potassium in the gut, and then we poop it out. You can give furosemide, a loop diuretic, so we pee it out, and we can put them on hemodialysis. So it's kind of a three-tiered approach to treat hyperkalemia. We stabilize the cardiac membrane, we drive potassium into the cells, and then we excrete it somehow, right? Or we remove it from the system. All right. My last question for the series. What are the three mechanisms of humoral hypercalcemia of malignancy? So pause your screen and consider. Again, every concept I've discussed is extremely high yield. We're integrating, but I also, just like adrenal pathology, on every MBME exam I've taken, there has been at least one, if not multiple, questions on mechanisms of hypercalcemia. They love it. So three mechanisms, the three major mechanisms of humoral hypercalcemia malignancy. We've got PTHrP production, usually secondary to squamous cell cancer of the lung, and renal cell carcinoma. So real quick, parathyroid hormone. We've got 4 parathyroid glands sitting behind the thyroid. They have CGRPs. They sense calcium levels. So when calcium is normal or elevated, they bind to these CGRPs and they tell the chief cells, no more PTH. We don't need any, right? So when calcium starts to dip, we're losing that negative feedback. PTH gets released from chief cells. PTH does a number of things. Goes down to the osteoclast, stimulates the osteoclast. They chew up bone. We increase the amount of calcium and phosphate. PTH goes down to the kidney, and it blocks reabsorption of phosphate at the proximal convoluted tubule, so we pee out phosphate. It causes reabsorption of calcium at the distal convoluted tubule, so we increase calcium. And then it goes to the proximal convoluted tubule, and it upregulates 1-alpha hydroxylase. 1-alpha hydroxylase is the enzyme that takes 25-OHD. That's the stored form of vitamin D in my liver, and it converts it to 125-OHD, which is the metabolically active form of vitamin D that goes to the gut and increases calcium reabsorption. So overall, parathyroid increases serum calcium, decreases serum phosphate. All right. PTHrP acts exactly the same, but it has no impact on activation of 1-alpha hydroxylase. Small point, I doubt they would ever ask that on a board exam, but if you want to be an absolute baddie, I would know that point, right? If you want to impress me, I would know that point, all right? But at the end of the day, it's going to increase serum calcium, decrease phosphate, and then you're going to check the patient's PTH, and their PTH will be low because, hey, their calcium's elevated, and it's going to feed back and shut down PTH. And then we have our own lab assay where we can check for PTHrP, all right? The next mechanism would be osteoclast activating factor. It tends to be IL-1 driven, and that tends to be multiple myeloma, right? Multiple myeloma is a plasma cell dyscrasia. We're making too many plasma cells, and those plasma cells can secrete IL-1. The IL-1 stimulates osteoclasts. We chew up bone, increase calcium. Remember, with multiple myeloma, we tend to see the CRAB symptoms: hypercalcemia, renal insufficiency, anemia, back pain, bone lytic lesions. So those are some other things. I've talked about multiple myeloma in many lectures. I have a whole lecture on it on YouTube as well. And the last mechanism would be upregulation of 1-alpha hydroxylase itself, which is usually secondary to lymphomas. So you probably are familiar with this mechanism in sarcoidosis, TB, Crohn's, borreliosis, histoplasmosis, where we get granulomatous formation, and those activated macrophages upregulate 1-alpha hydroxylase. So those are also examples, but those aren't examples of cancers, right? I'm asking about humoral hypercalcemia malignancy. So lymphomas are also classically linked to upregulating 1-alpha hydroxylase and then upregulating vitamin D, so then increase in serum calcium. Very important concepts. So there's everything there. So take a screenshot if you need. I didn't really talk about it, but symptoms of hypercalcemia would be stones, bones, groans, psychiatric overtones. So kidney stones, bone pain, constipation, GERD. We also can see depression, brain fog, altered mental status, and then hypercalcemia can shorten the QT. Hypocalcemia prolongs the QT. Hypocalcemia can also cause tetany. So we can see Chvostek's sign when we're tapping on our facial nerve, right, and it's overactive. We could see Trousseau's sign where I put a blood pressure cuff on their brachial artery, and then their hand spasms, we get a carpal spasm. And then they also have perioral numbness tingling in the fingers and toes. We classically see significant hypocalcemia after a thyroidectomy or parathyroidectomy. In a thyroidectomy, right, we end up could accidentally remove the parathyroid by accident, right? And then obviously you're missing your parathyroid. We can't regulate our calcium as well. Um, to treat hypercalcemia that's causing significant symptoms, IV fluids are always the first line. Dilute out that calcium, protect the kidneys, right? We already talked about calcium can hurt the kidneys. Next thing we can do, we can give calcitonin, which works now. It inhibits osteoclast. And then I can give bisphosphonates that take, 48, 72 hours to really kick in. But those will work for a very extended period of time to cause osteoclast apoptosis to then reduce that calcium. All right. Ton of information, hour-long lecture. Really, this is the level of knowledge I want you to have, right? When you are a doctor, you are presented with, so many different things. You have to sit there and you have to integrate, right? You have to integrate it into the story. I often tell my students who are new onto the wards or onto their rotation, you need to tell the story of the patient, right? When you're on rounds and you're presenting a patient to your attending, you are telling the patient's story, okay? You are trying to paint the picture so the attending knows exactly what's going on, right? You need to paint the story and you need to become a master of the physiology and pathophys because as you saw in all these questions, if you understand the physiology and the pathophys, I know exactly how to diagnose, I know exactly how to manage, right? And I know exactly how to explain it to my patients so they know exactly what's going on in their body. That is the level of clinical mastery you want. That is what I want from you and I expect from you. So keep doing good things, keep working hard, and until next time, all right?